Good morning, everyone. My name is Christina, and I will be today's webinar moderator. Welcome to today's webinar entitled Blood Banking in BMT, presented by Dr. Christine Cserti-Gazdewich. Dr. Christine Cserti-Gazdewich completed her training in internal medicine and hematology in Toronto, followed by a fellowship in transfusion medicine at the Harvard Joint Program in Boston. She returned to Toronto in 2006 in the post of Assistant Professor at the University of Toronto. At the University Health Network, she serves as a transfusion medicine specialist and a clinical hematologist. Her professional activities focus on transfusion, immunohematology, and hemovigilance locally, as well as the hematology and hemotherapy of anemia in less developed countries. Through the laboratory medicine program, she and her transfusion medicine colleagues from UHN and Sunnybrook also act as remote medical directors to numerous Ontario facilities. Before we get started, I'd like to briefly go over the format of this webinar. There will be two parts, a 45-minute presentation segment and a 15-minute question and answer session. All phone lines will be placed on mute during the presentation. You may post written questions during the webinar by using the chat box located to the right of the slides. After the presentation, Dr. Cserti-Gazdewich will answer all written questions. When there are no further written questions, I will take questions by phone. Should you experience technical difficulties, an operator can be reached by pressing star followed by 0 on your telephone. At this time, I would like to present you to today's speaker. Dr. Cserti-Gazdewich, you may begin your presentation.
Thank you so much, Christina, and thank you so much for the privilege and excitement of sharing time with the esteemed CBMTG audience. So to begin, I don't have any meaningful disclosures or conflicts or warnings. As mentioned, I work in downtown Toronto, but our reach includes many rural hospitals across Ontario, about 30 to be precise, and the feeding dozen or so blood banks that bring the products to serve the patients. And as this BMT audience well appreciates, although we offer the service of BMT at quaternary centers, we serve patients who come from far and wide and then release them back into the community where transfusion care may continue to be an issue. So I hope I can speak to a number of concerns, and when I polled some colleagues on what they favored as the top topics for transfusion BMT overlap, the most popular requests were to have a discussion on priority antigen systems and how we deal with the dynamism of mixed blood types, to delve a little bit into what special modifications are mandatory and why, and to also discuss the clinical challenge of platelet transfusion refractoriness. So I'm going to have 5 questions embedded through the talk just to test our knowledge. And at the very end, as mentioned, we're going to hope for a quarter of the hour to be dedicated to Q&A and discussion. So I also want to acknowledge that we're coming on the 200-year anniversary of blood transfusion next year, and that will also overlap with the unification of the International Society of Blood Transfusions meeting being hosted in Canada through the Canadian Society for Transfusion Medicine. So for those who have an interest in this, this will be a jubilant time intellectually together to be in Toronto next summer. The other issue, though, is that although blood transfusion has a 200-year history, we've only been really offering this service for the last 100 years. And the thing that allowed us to get that far is the additives that get us through space-time, which is to say that we can separate blood from the donor's body and not have it clot off by the addition of citrate, and then nourish those red cells as they're stored ex vivo with no nutrient supply through the provision of dextrose. And back in World War II days, this was a 3-week storage time, but we've certainly pushed those limits to 5 and 6 weeks since the 1970s and 1980s. So some may be surprised to know that even though there's been this long history of transfusion as a pretty elemental standard of care, and we do appreciate also that transfusions are probably the most frequently performed procedures across any admissions in the developed world. That is to say 10 to 15% of all admissions involve a transfusion. Blood products, components that is, red cells and platelets only made the list for the WHO Essential Medicines in April of 2013 after the 18th edition. And so this is a document that is uploaded every 2 years. And so this speaks to the fact that there are many countries that don't even have this resource, which is absolutely critical for bone marrow transplantation to be able to occur. And so this little history shows how we were sort of ahead by half a century to enable bone marrow transplantation to occur. And it was as the capacity to hatch off platelets from whole blood was developed in the 40s and 50s that stem cell infusions became an experimental reality and then broadened decade by decade into different enhancements. And we know that when we condition patients to enable the receipt of a graft to repopulate their hematolymphoid identity, that this gouging out really requires the support of red cells, platelets, and on occasion plasma or cryoprecipitates, particularly for DIC type or hepatic coagulopathic complications, and very rarely, and something I won't touch on in this talk, granulocyte transfusions. So the emphasis for our time together is red cells and platelets. So there remain a lot of questions even in 2017, even though there's been a lot of transfusion experience. We don't have a good sense of how much is too little and how much is too much. What's the therapeutic window, and when you trigger, what's the right order size? In hemovigilance terms, what are the bad things that can happen, and is there anything peculiar to the BMT patient with transfusion care? And with special modifications, are we resolved on what those need to be? And how good are we at the IT assurance of this occurring? And how do we insinuate alternatives, especially as we imagine a potential reality of bloodless transplantation, especially if pushed to that envelope limit by a Jehovah's Witness patient presenting to us? So we have these notions of various times to engraftment defined variably, and the numbers depend on so many things, but just to list a few of them, and to also express the caveat that whatever utilization we quote or see in a paper, that this is going to be founded on how the institution at stake triggers, what are their internal guidelines, and how much do they give in a dispensation, what's the case mix of the patients that are served, what's the treatment era that you're talking about, what's the conditioning regimen, and what's the nature of your stem cells, the source and the dose, and how much mismatch have you got with perhaps antagonistic sensitization, and how much immunosuppression are you offering to get people through. And so all of these multifactorial complexities speak to the statistical diversity we see in utilization. And to speak a little further to that, this slide here shows what some of the trends have been over time, particularly with red cells. So back before Energeros Xenocostas profiled what our use of blood products were, red cells specifically in allo-BMT, it was at a median a dozen, and that's gone down to about half that load if we look at more recent literature. So let's assume 6 units of red cells as a low median figure. So that's come down quite a bit over time. What hasn't come down quite so much is the amount of platelet transfusion support over a similar period of literature review. So if we assume that a patient takes 6 sets of platelets and 6 red cells, and we have to irradiate those cellular components, we're talking about a minimum support cost estimate of 4,200 Canadian dollars for these blood products, which is peanuts compared to the transplantation regimen itself and even some of the antibiotics. So there are these 2 axes and what troubles we might anticipate or toxicities we may expect with a transplantation, and the myelosuppressive axis will speak to how prolonged the transfusion-dependent cytopenias may be. But also interacting with that is how mismatched the patient may be, because if there are preset immunities in either direction, there could be some hemolytic or cytopenic fallout, and the immunosuppression itself may then also engender toxicities, as might the infection complications that follow. So there are prices to pay, and it's hard to imagine being able to do this without transfusion support. But it's not too surprising that we've been able to cut down red cell utilization, because I think the message of the non-necessity of liberalism has come through well and strong. And I think the most important systematic review or meta-analysis just came out in JAMA by Carson et al. And took all the death counts from over 20 RCTs and showed that there's absolutely no signal of mortality in using restrictive triggers. And if anything, although the confidence interval on this is not statistically significant, you might actually have fewer deaths by triggering restrictively. It's disappointing that we can't recapitulate the higher survival rates or lower mortalities at the higher hemoglobins we try to contrive by transfusion. And as we imagine why that is, things like the storage lesion have been scapegoated. And so I think there's in the public consciousness this idea that banked blood surely can't perform as well as one's own natural blood, and as a result, perhaps we ought not overuse it. The very important TRIST trial was presented at ASH, and if anyone doesn't buy the generalizability of tens of thousands of people in a systematic review, this will address the question for most transplanters on the trigger context in auto and allogeneic stem cell patients. And so in the RCT to examine a sub-70 versus sub-90 trigger, there was no difference in a quality of life FACT BMT score measure over time. And even other endpoints weren't all that off, so no clinically important differences for many of the endpoints we pay attention to. And although there's a 14-point hemoglobin difference and slightly higher blood use, it doesn't really amount to anything. So why use more of a resource if the outcomes are the same? Okay, so for part one in why systems or which systems matter at the red cell level, I'm going to be talking about what they are, what's major and minor in system terms, and what's major and minor as we speak about the polarities of mismatch. So there are two notions of major and minor that we're going to face in the next few minutes. So I want to also point out that at a very basic level, the antibody isotype that we're looking at gives us a clue as to clinical significance and also what the target may be. So IgMs are incited and held as such by carbohydrate antigens, and they can react under room temperature conditions and be evident even without testing reagents. And so this is really the dominant antibody in the ABO system. But it's the IgGs that are not naturally occurring but rather provoked by alloantigen exposures. And these are a little hard to see because these antibodies don't naturally pentamerize at room temperature. And so we need reagents to detect the existence of potentially hemolytic IgG antibodies targeting foreign alloantigens. And the detector reagent for that is AHG antihuman globulin, also known as Coombs. So to pay homage to some history here, it was Karl Landsteiner who discovered the ABO system, and it was not by any fancy reagents. This was in the pre-Coombs era. This was by observing agglutination by the mixing of some colleagues' blood with others, and not in alternative combinations. So there are some people who looked compatible versus incompatible with each other, and he broke that down and discovered the ABO system. Things really changed after Sir Robin Coombs, a veterinarian, half a century later, and what he brought as a tool to us is the anti-IgG or anti-human globulin, which enabled us to see the effect of IgG. IgM would pentamerize and agglutinate red cells together visibly, but IgGs landing on a target wouldn't be visible to the naked eye or through the microscope. We can't see this agglutinating red cells. You can produce agglutination by an anti-IgG linking IgG-sensitized red cells together. So after Coombs offered Coombs to the world, there was an interesting timeline for the discovery of many red cell antigen systems. And we thought we were going to cap out in the 1980s, but then there was a small golden era just a few years ago, 5 years ago, where a little cluster of new red cell antigen systems were discovered. And the most recent count as of 2017 is shown here. Some of this is erythrogene data, so there's a database that keeps track of red cell polymorphisms as predicted by genotypic differences in people. Not all of these are going to be immunogenic or clinically relevant. When it comes to reference serology lab information, there are over 353 red cell alloantibodies out there that we know of to date that humans have made after transfusion or pregnancy, and it's over 300 antibodies as such that we're hunting down in the screen when we submit a group and screen to the blood bank. So those 2 or 3 lowly screening cells are telling us yes or no, are there antibodies to over 300 potentially incompatible red cell structures. So this is where we are today. You can divide red cell antigen systems into major versus minor systems. And we segregate the majors out as ABO and RHD because they've got clinical significance. ABO because there is this pre-existing repertoire of antibodies that you can't cross the barrier on. Otherwise, the mistake could lead to a fatal hemolytic transfusion reaction. RHD is not beset with naturally occurring antibodies, but in this all or nothing expression of this 12 transmembrane path molecule, a D-negative person has a very high odds of seroconverting to the D structure if they see it. And that has huge importance for a woman of childbearing age because that may then lead to HDSN, hemolytic disease of the fetus and newborn. So this all or nothing antigen presentation produces isoimmunization when the negative individual sees the missing structure. On the other hand, alloimmunization events speak to the minor antigen systems where you and I all carry these proteins, but you and I have different versions of them. And so by single nucleotide polymorphisms that create very discrete amino acid changes, which are immunogenic more or less in some people, if I get transfused with blood that has a different protein version of what I've got, I may alloimmunize to that different target. So that's called alloimmunization, and that's a lower odds event. Whereas isoimmunization is either 100% for ABO and at very high percentage ranges, which I'll show you in a few minutes for RHD. The odds of alloimmunization to these minor systems is running much lower. Okay, so when you submit a sample to the blood bank, we're kind of like the court of law. We're looking at direct and indirect evidence. And for us, the organ of interest is the discohesive red cell biomass, and there we're going to interrogate your patient's red cell type by ABO and RHD, plus or minus determine the expression of other phenotypes that we may be interested in providing extended matches for. And if you're querying whether or not your patient's current red cell biomass, whatever its mix may be, is under immune attack, we have a polyspecific Coombs reagent that looks for the deposition of complement or IgG on your patient's erythroid mix. And so that's the direct Coombs test. When we flip over to the yellow stuff, that's called surmising indirect evidence. And so we can confirm that your patient follows Landsteiner's law and has the expected reciprocal antibodies in the ABO system. Or we can look for antibodies not yet attached to the alloantigen target in the indirect Coombs test, and that's the screen. Here we're using group O screening cells because we're not asking the ABO question anymore. We're looking at what targets outside of the ABO systems your patient may have antibodies to that we must match for, because this may predict a hemolytic immune incompatibility. And you can also take your patient's plasma to perform in vitro cross matches to likewise predict what happens. And the Coombs reagent we use to see if this is attaching to this is again anti-human globulin, but doesn't carry the baggage of anti-complement antibodies. We're only looking for anti-IgG. Okay, so the testing orbitals of the blood bank, there's 3 of them: groups, screens, and cross matches. So to summarize, grouping is about ABO and RHD typing. This tells us if we're adhering to Landsteiner's law and avoiding the offense of any fetal erythroid hemolysis. The screen is to see whether or not there are any non-ABO antibodies. It's a theoretical snapshot of what other baggage your patient may have towards non-ABO targets. If positive, your patient's got trouble. If negative, they seem good to go. And the cross-matching answers the question of whether or not the proposed unit is indeed compatible with your patient's current sample. So with matching, we would match for ABO-RHD for you and I, and this is because the aforementioned alloimmunization odds for all comers is between 1 and 10% for someone who's got transfusion or pregnancy under their belt. We sometimes match a little further, something called PAM, or prophylactic antigen matching. I like to call this a 5-way match. We'll add CE and Kel to the mix. Kel is a popular add-on to prevent women from Kel-ISA immunization because that's also a pregnancy issue. But C and E are also very immunogenic, and so you can cover a lot of alloimmunization, particularly for high immune responder groups like sickle cell, where there's an exaggerated disparity between the distributions seen in donors versus recipients at the different blood types, the minor red cell antigen types. If someone's made a number of alloantibodies, or you want to abdicate the need to keep hunting or analyzing for the occurrence of these, you can do really extended matching. So adding to your 5-way match, Duffy Kid and S matching. And so we'll do that for some people who are highly alloimmunized or who have warm autos that are hard to see through, so that we don't have to see what else they're seroconverting to. Okay, unfortunately, we use the term major and minor as well to describe what kind of incompatibility a patient may be facing. So in addition to using the term major and minor for different systems, you can use major and minor to describe hostility. Major incompatibility, and this is a little egocentric, implies that something alien is coming in and there are cellular donor antigens that the host is capable of attacking out. And so these are all examples of product rejection. So the host is the fighter in major incompatibility. Minor incompatibility is the mirror image of that. And here the host is innocent. It is the incoming donor that swoops with their antagonism, and the donor source immunity is what mounts the attack. And there's nothing minor about minor, because transfusion-associated graft versus host disease is an example of minor incompatibility, and so is the commonest cause of transfusion-related death, which is TRALI, transfusion-related acute lung injury. So when the host is getting rejected by a fighting donor, these are examples. This is preformed passive or active passenger lymphocyte immunity that can attack your host. Okay, so ABO, which is a very popular topic in BMT and antigen mismatch discussions. This is a carbohydrate system, and it's encoded by genetic glycosyl transferases, and it reflects a codominant antigen expression system. H is the antigen that's expressed in someone who's O, but if you have an allele to decorate with the A or the B sugar, you will express that. The A sugar is GalNAc N-acetylgalactosamine, and the B sugar is galactose, and so you can be A or B or O or AB as a result. In this example of how we do a blood type, this individual is forward grouping with the anti-B reagent as group B, and they're obeying Landsteiner's law on reverse or back typing with their plasma exhibiting agglutination activity towards A cells. So this is anti-A in a group B person, and their typing is RHD negative. So this is an example of a completely non-discrepant normal blood type group B neg. So the interactions at stake in the ABO quagmire reflect this immunity that people develop very early in life over the first 3 to 6 months. And ABO is truly a histocompatibility antigen system, although it's most densely expressed on the red cells at 1 to 5 million sites. We also have some ABO expression on platelets and on the endothelia of our organs, which is why this is also an important barrier in solid organ transplantation. And people secrete their ABO types more or less into their plasma and into their secretions. And so when we have a person with a given ABO type, what's of relevance to them is what ABO isohemagglutinins they may be facing. This is the current global distribution of ABO types around the world, although this is different from nation to nation. And you can see the group O is the most common blood type, but it's rife with lots of isohemagglutinins. And so although the group O individual is a universal red cell donor, because there's no A or B structures on their red cells, they've got the nastiest plasma. And the mnemonic here, and I don't mean to sound political, is that the GOP is deadly. So group O plasma has anti-A and anti-B, and that's exactly what makes the group O person so vulnerable if you cross the ABO barrier on them with an accidental red cell transfusion of the wrong ABO type. By virtue of this fact, the plasma of a group O individual can be hemolytic towards everyone else here in color. And so we all know that Landsteiner's law would predict for these isohemagglutinins in A's and B's. And AB is the universal plasma donor because there's no anti-A or anti-B antibodies in these low-frequency individuals. the ratio of O's to A's is 10 to 1, and so it's much harder to get AB plasma than it is to get group O anything. Major incompatibility in the world of BMT or mistakes happens 5 different ways. This is about any non-O structure on the cells coming into an O recipient who has isohemagglutinins, or ABs coming into an A or a B. Okay? AB brings A to an A, which they've got antibodies against, and so on and so forth. When we have a major incompatibility scenario, isohemagglutinins may continue to get secreted in accordance with how intense the conditioning was, so there's a reciprocal relationship there, for the next 3 to 4 months after transplant. And the price of this is pure red cell aplasia or delayed erythroid engraftment, and that's going to occur more often the less powerful your ablation regimen is. So the non-myeloablatives will continue to have this host plasma cell ABO immunity getting secreted out. The mirror image of minor incompatibility occurs also 5 ways. So this is about any O's into non-O's. All those ABO antibodies can come in, or A's or B's into an AB. The difference being A secretes anti-B, and that's of relevance to an AB donor. And here, the donor side isohemagglutinins from the passenger lymphocytes may only become detectable if they weren't already in the graft at infusion point 1 to 2 weeks later. So it takes time to secrete this junk out. And what you'll see is a DAT-positive intravascular hemolytic anemia, which we'll refer to as passenger lymphocyte syndrome. And this usually subsides in a fortnight. The worst of all is bidirectional incompatibility, and this cartoon should illustrate just how messy this is. And so these are the types of ABO incompatibility resummarized. So the most daring transplants are called the major incompatibilities. So here you're seeing something that you don't have. Minor incompatibilities are the deadliest plasmas. These are the passenger lymphocyte syndromes, or the things that might lead to PVRing of the graft. And double jeopardy, again, bidirectional. So in solid organ transplantation, ABO matters a lot more than HLA, because a lot of people don't have preset donor-specific antibodies. BMT or solid organ transplant folks will try to avoid ABO incompatible solid organ transplantation, and if they have to do this, they'll invoke a lot of immune suppression. But in HSCT, we care absolute and foremost about HLA, and so we sacrifice ABO and we'll take everything if there's a really good HLA match. So we've got all 4 scenarios to deal with in our world. Unfortunately, when we're panning from matched unrelated donors, about 2/3 is the statistical odds that you're going to have an ABO mismatch. And of course that odds is going to be much higher than what the odds are of ABO mismatch from matched sibling related donors, because you're coming from the same pedigree with the same parents. And so the odds of concomitant ABO matching are going to be higher. And I think we need to separate this confounder when we analyze outcomes of MSRDs versus MUDs. At UHN, and I'm not sure, and I'd like to hear more about this from other listeners, we have a convention in our lab information system to signify that a patient is now chimeric by virtue of BMT. And so blood types are no longer A's, B's, ABs, or O's. We have a suffix T dash dash, and we fill that dash in with the blood type that the patient was born with and what they got transplanted towards. What is their donor's type? And so these are examples of different scripts or reclassifications of BMT patients once the stem cell infusion has occurred. And this allows us to generate truth tables which take away from the technologist any imputation or decision-making risks related to the selection of an appropriate red cell, platelet, or plasma. So let's talk about the graft. Grafts, as we know, are either bone marrow or peripheral blood stem cells. And the issue with bone marrow allografts is there's a lot more plasma and red cells. And so this might mean that you have to decant hostilities if either of these component faces are incompatible. The cleanup options are shown in this table, and this comes from Nina Worrell out of Austria. Not everybody does all of these things, but this is sort of the most intense scenario table if someone were to want to be interventionalist in their management of incompatibilities. So this table is organized by major, minor, and bidirectional pairings. And you can look at the picture by the isohemagglutinins, high or low in these scenarios, and consider either graft manipulation or apheresis of the patient to minimize these ABO hostilities. So if you have a high titer donor, if you have a major mismatched donor and the recipient has a high ABO antibody titer, then you're going to be compelled to red cell reduce the graft. Now, this is rarely an issue or need in stem cells, but if you have bone marrow or a lot of red cell contamination, RBC depletion is recommended. Low titers, however, in your recipient, not so much an issue. Now, many blood banks aren't offering the service to titer the recipient out in advance of the transplant, but some centers are. And the other thing that some centers are doing is apheresing down the host's pre-transplant titer to minimize erythroid destruction of the incoming graft. So some interesting propositions have included deliberately infusing incompatible red cells of the donor type in small aliquots, 10 to 50 cc's, something that should be beneath the fatal threshold, to immunoabsorb out or quench out the antibodies, hoping also that the conditioning itself stops the future wave of isoagglutinins from being formed. In minor mismatch, we're now worried about the donor's ABO antibody titer. And if you have a high titer donor, you may want to plasma volume reduce your graft. But if you have a low titer donor, maybe not so important. If you have a vulnerable recipient, some people have proposed also exchanging the red cell type for something less vulnerable, but that's harder to do in an era of group O red cell conservation. And finally, bidirectional grafts, as messy as these are, also impose the greatest risk of graft manipulation, which if you're stripping off red cells and plasma, any maneuver will have the risk of decreasing your CD34 load. Okay, so there are clinical archetypes for the different mismatches that you might confront. The major incompatible stem cell transplant is about a red cell adoption failure, and so this is graft reticulocytopenia leading to pallid anemia. The mirror image is the plasma incompatible or minor mismatched transplant. And so here the historical or residual recipient red cells begin to burn off in a hemolytic way. These are already preformed red cells, and so you may see hemolytic jaundiced anemia in these folks if they have a lot of their residual red cell type remaining. Okay, this here is an example, a very colorful one, of truth tables. So for major, minor, and bidirectionally mismatched transplants, I just want to call your attention to the fact that the common thread for red cell support is group O RBCs. You can't go wrong with these as the bridge until the donor's red cell type fully engrafts. And the definition of that is when the host's isohemagglutinin, such as those of a group O person, disappear and the DAT is now negative. At that point, you can switch over to the donor's blood type. For platelets, it's the reverse. We don't care so much about the platelet survival, although some people might think that we should. What we worry the most about is any isohemagglutinin load from the plasma that the platelets are suspended in. And so here we'll err on the side of thrombocyte mismatch to ensure that the plasma here is not hemolytic. And so we'll always favor the major mismatch platelet type and not switch over to O until the very last. That's the lowest rank choice. And the same applies for plasmin. So to summarize, again, the common thread here is O's for erythrocytes and AB's for plasma and platelets. But again, I mentioned AB is the rarest of all the ABO blood types, only 4% versus 45% for O. Other people have proposed temporal schema for what to give when, and this depends on the stomach that information systems and labs and staff have for algorithmic presets and complexity. So one way to put this is that you always start off with your recipient's group. You always end off at some point with the donor's group, we hope. And in between, you're either giving group O, or if it's a major mismatch, staying with the recipient's lesser group. And if you are minor mismatched, again, extending the lesser group out. So this is another way to look at this, but I don't want to ponder this image too long for fear of stealing time from other content. I think the bottom line that everyone listening in wants to know is what's the clinical evidence that there's badness from all of this ABO mismatching, which is a reality. And the short answer to that is that we're uncertain. So in the 19 papers reviewed in Worrell's very impressive paper last year, she looked at all of the different clinical outcomes that were reported by different groups. And really, overall, although there's some evidence for impairment or bad outcomes in some of these, there are as many papers to suggest the opposite, i.e. no impact for things like various times to engraftment or GVHD or overall survival. So this means that ABO certainly takes a lower rank when we look at all the priority settings for stem cell donor selection. I just want to illustrate with this case that sometimes we have really complicated patients or donor-recipient pairings. In this case, we have a major-minor, minor-major, and I'm not being facetious. So here we have a Group O donor who is studied also with the E antigen, donating to a Group A host who has anti-E on her screen, in the group and screen. This is a minor mismatched ABO transplant. It's a minor mismatch of a major antigen. And there's also a major mismatch, a foreign alien confrontation to something that this host has preset immunity towards. So this is a minor antigen with major incompatibility. So it can be difficult to summarize this, and when you do this too much, it can be very confusing to people. But the bottom line is that you've simply got to look both ways before you cross the street and find middle ground. And so the goal is to look at who could attack who and settle on the product that is least offensive to both parties. That's the only way to problem solve any theoretical scenario in a test or in reality. And now to talk about RH. RH is not expressed on platelets, but we pay a lot of attention to the RH type of the platelets that we select for people, simply because there's erythrocyte contamination of every platelet product. And that small amount of erythrocyte contamination can be enough to sensitize someone. And we care a lot about that, particularly in our young hem-onc patients who are still of childbearing age and who may wish to have children in the future. And so these are our patients who are the priority for the provision of RHD negative products. This graphic here summarizes literature on what the odds are of RHD seroconversion depending on what product you're giving and how intact the immune system is. And so we know that healthy volunteers, if they see D-positive erythrocytes, are very prone at high rates to complete isoimmunization. But immune-competent patients, by virtue of their illness, have a somewhat dampened immune responder status for various reasons. Still a high percentage. What's very interesting is how wide the range is for D seroconversion when healthy people see platelets. And so this just speaks to how immunogenic that contaminating red cell mass is in a platelet transfusion. But what do we care about? Our immune-compromised patients, if they get a D-positive platelet, what are the odds of them making anti-D? It's less than 1.5%. And the most important study to clarify this figure was the ADAPT trial published in BJH 2 years ago now. How much residual contamination do you have of red cells in a platelet? Well, for starters, 13 times as much in a Buffy-Coat pool of 4 than from an apheresis donor. And the overall volume is just microliters. And so if you have no RHD negative platelets and you have a female of childbearing age, you can immunoprophylax her with Winro, although that's going to make her have a positive screen and interfere or slow down cross matches in the future, or give apheresis platelets from an Rh positive donor and worry less about the odds of her seroconversion because the seroconversion risk is so low. Okay, so a question now. Which of the following is most expected in the following transplant scenarios? A, is the odds of having an ABO match as good between unrelateds as in siblings? Do D-pos-neg pairs seroconvert often in transplantation? Are D-positive platelet concentrates immunogenic? Do ABO major mismatches lead to delayed red cell engraftment? Or is ABO minor mismatch prone to pure red cell aplasia? Are people able to vote? Okay, in the interest of time, the answer to this is D. Okay, so there's a 30% odds of delayed red cell engraftment in ABO major mismatch. Minor mismatch is a passenger lymphocyte syndrome problem. So PRCA kind of goes with DRE here in major mismatch. We just stated that D positive platelet concentrates are not as immunogenic as people might have feared. If you have D mismatched transplants, probably less than 10% seroconversions will be seen, and we know that MUDs are more likely to be ABO mismatched than SIBs. Oh, okay. I'm sorry about this. Okay, fantastic. Everybody knows the right answer. Great. Part 2, special needs, product modifications that are relevant and necessary. So we don't have to worry about leukoreduction in Canada, but if I was giving this talk in the States, this is a modification that people have to actively order in many blood banks. And by virtue of leukoreduction, we've cut down on the risks of many of the bad things that white cells carry into people. There are unfortunately many product-specific attributes that you can request, and not all of this information comes with the patient as their healthcare gets fragmented from site to site. But this table is meant to offer a dizzying visual of just how many questions you may ask about what a patient may need. And so we wish that this could come across with our patients better, but it is a limitation. And one of the questions that we ask about how to better communicate what our patients' special needs are, especially as we send BMT patients out into the community, is who runs the blood bank? Is it separate from who runs the stem cell lab? And are the information systems shared? And what we're still doing is old school carding and letters. And this is, quite frankly, just an antediluvian workaround. The real solution system of which is open gates on respected confidential information that goes from computer system to computer system without overly invoking time and effort from the bedside clinician. Otherwise, it's us that's advocating for the patient and trying to think through all of what the patient's needs may be and then communicating that to the blood bank. This here is an example of the National Health Services radiation card that might be given to a BMT patient. And so many people, lament the fact that we've got so much surveillance on us, but the relevant information for our health is never there, even though it probably exists. And I would say that that's probably true even for ICD codes. I always fantasize that, a code for fludarabine or CLL ought to be coming automatically to my blood bank rather than depending on human effort to communicate that and the irradiation need. And even though patients have cards, I can attest to the fact that these have failed. We sent out a medical staff bulletin a few months ago begging people to ask again about whether or not your patient has an antibody card that might already speak to their special needs. And this is probably an even more important message for community hospitals to heed. Now for irradiation, to prevent transfusion-associated graft-versus-host disease, this remains the only technology right now, but coming in the pipeline when we have pathogen-inactivated platelets, and that will be coming in Canada. This will not only mitigate the risk of transmissible infections, but also induce enough DNA damage that any residual lymphocytes after leukoreduction will not harm our patients. GVHD, transfusion-associated GVHD, is really a big risk with platelets because they're always transfused within the window of lymphoid viability. In our systematic review of TA-GVHD, there's never been a case out of over 300 case reports of anyone getting GVHD from a blood product stored for more than 14 days. And most red cells are dispensed after the 14-day point. So I'm not as worried if there's a mistake in healthcare with a red cell being non-irradiated, but it's certainly relevant if a platelet gets into a patient unirradiated. And the odds of demise from TA-GVHD is very high. Case fatality rates are 90%, and the timeline to death is typically within a month. And so when we close the loop on when someone had a non-irradiated unit as a medical error, we check in on the case 28 days afterwards to see what happened and then close the case. As for CMV, to summarize, this really ought not be an issue. Back in the old days, and courtesy of the Canadian Consensus Conference, it was said that if you were a neg-neg pair, that you were entitled to 2 safety measures, that is, leukoreduced as well as seronegative donors. And some of us jokingly refer to this as the belt and suspenders approach. And so the super safe option people have been questioning. And the only way to really compel people to not ask for so much is to either convince them that what we think is good about seronegative is bad, or to reassure people that what we thought was bad about seropositives is not truly so. And there is some evidence on either of these thoughts. For example, a seronegative person might actually be in their window period and be infectious. And conversely, the seropositive person, if they were remotely infected, carries more anti-CMV immunity in the way of their passive anti-CMV IgG than they do in any replicatable virus in the leftover white cells with leukoreduction. I give praise to this important Ottawa publication that looked at two eras of transfusion support in the CMV neg-neg BMTs, and when they looked at leukoreduction only, i.e. not picking blood products from seronegative donors deliberately any longer, there wasn't a statistical difference in the infection or CMV disease outcomes for these patients. So I think that relieves us. Okay, so for the next vote. All but the following is true of cellular component irradiation. On-site, you incur higher costs and risks, or off-site, there's hypersenescence of the red cell product, or the need is only temporary in stem cell transplant, or irradiation mitigates the risk of Bacon, or irradiation also applies to stem cell donors. Let's vote. Okay, so there's a pretty wide mix. It is true, actually, that irradiation increases the cost of blood service provision. It's about $8 in extra cost per irradiated unit, and the other cost is increased turnover because you short date the unit. That speaks to point B. Yes, irradiation increases hypersenescence of the stored product if you irradiate before storage and administration. So that is true. The need in BMT, some people are relieving their patients of the irradiation need after they've fully engrafted, and so some people will, after auto stem cell transplants, relieve the need for irradiation, and after 5 years after allo, similarly relieve the need. Others will administratively fix people for indefinite irradiation simply for logistic reasons, but that is not necessary. So D is the only thing that's not true. Here. Sorry, irradiation does not mitigate the risk of Bacon, so I'm glad that that was the majority response. And it is true that you should irradiate if you are transfusing your stem cell donor because any lymphocytes from a blood transfusion going into your allograft can then come back to life when you thaw your cryopreserved stem cell graft. So you could get a delayed TAGVHD of your allograft if the stem cell donor gets transfused with non-irradiated blood. Okay, last part here, platelet refractoriness. So platelets seem to be a pretty yucky product. They're certainly the most reactogenic of all of the things that we give. And in BMT specifically, there might be an added risk from the inflammatory nature of these products towards promoting pulmonary syndromes. We're familiar now with various guidelines on when to trigger. So there's a lot of literature on that now. And refractoriness may not be able to achieve these endpoints if you are transfusing platelets for various procedures. And so the definition of refractoriness, for us at least, to make it simple, is failing to increment by more than delta 10, although the formal definition is not getting a corrected count increment of greater than 7.5. And the best way to assess refractoriness is to cover the age and ABO of the product. So apply your scrutiny to a fresh ABO match before you call refractoriness. For ABO, again, Group O is the least desirable of all ABO types when we give platelet transfusions. And everything else that might be a mismatch is not as undesirable as Group O. Platelets carry 3 different antigen systems, ABO, HLA, and HPA. The most densely expressed is HPA, although it's the least worrisome to us because this is the least polymorphic of the systems. HLA, however, as we all know, is very polymorphic, and we express a lot more HLA on our platelets than ABO sites. And so this is why this may take priority in platelet transfusion support. As well, platelets are suspended in plasma, and so we can hurt our patients with the plasma that our donor platelets are suspended in. They're the ABO isohemagglutinin, and if we don't select the plasma that the platelets are suspended in carefully, you could have a trollygenic donor if there are HLA or HNA antibodies in the plasma that the platelets are suspended in. HLA alloimmunization has been much reduced but not eliminated by leukoreduction. And leukoreduction levels the field and equalizes the risk despite the diversity in pooled whole blood-derived platelets, with that seen in single donor apheresis platelets. And this was well shown in the famous TRAP study many years ago in the New England Journal of Medicine. The badness of host site HLA sensitization may be something as simple as manifesting more with febrile reactions, having platelet refractoriness. Patients who have HLA antibodies and platelet refractoriness have a higher odds of early ICU requirements after bone marrow transplantation. And of course, if you've got donor-specific antibodies, then the possibility of graft failure. Testing for HLA antibodies, old school was CDC or lymphocytotoxicity assays, and now relies on standardized solid phase reagents, so beads and flow luminex, and so on and so forth. And one of the things we've paid attention to, if it's very hard to find a match, is picking donors who express the antigen profiles that are the weakest targets of someone's antibody repertoire. And so what I'm speaking to here is permissive mismatching, a structural matching concept where instead of relying only on HLA matched donors, because that may be too narrow or small a number in the donor pool, opening this up to people who have similar HLA types in cross-reactive groups, and or avoiding the targets of the current antibody repertoire. So certain antibodies may evanesce and enable you to expose your patient to platelets. A big breakthrough in platelet transfusion refractoriness understanding last year, just as we know in ITP, is that a lot of this stuff is actually T-cell mediated. And so that was an interesting surprise, and we have yet to see what impact that's going to have on our care. Okay, so our last multiple choice questions, and they all relate to platelet choices. Which feature is prioritized in a male stem cell transplant patient early in his platelet transfusion care? Does he need D-negative donors if he's D-negative? Do we want to avoid major ABO mismatch? Do we want to avoid minor ABO mismatch? Do we favor CMV-neg if it's going to be a neg-neg BMT? Or do we want to start off with HLA single donor apheresis platelets over the random Buffy coats? All right, so for this question, we don't need to prioritize D because this is a man. We don't need to avoid major mismatch, and in fact, we'd rather that than minor mismatch. And so we would really prefer to avoid minor mismatch choice C because he could hemolyze from ABO plasma minor mismatched platelets. The CMV is not as big a priority. With blood products, we are to believe that our leukoreduced blood supply mitigates the risk as a single measure. We don't need to apply double safety if hemolysis is the alternative price. He's likelier to hemolyze than he is to contract CMV. And we don't need to start with HLA matching this gentleman. Okay, so let's permute this question a little bit. Now this is a childbearing age female who's also in the pre-transplant situation, and she's early in her transfusion care. Same choices. Do we want her to get D-negative donors for her platelets? Do we want to avoid major ABO mismatch, avoid minor ABO mismatch of her platelets, favor CMV-neg if she's going to be a neg-neg BMT pair, or favor upfront HLA platelet matching? Okay, so I would agree with the majority. So D negative donors are the priority for her. And last question here, which feature is prioritized? Once you have the kinetics of alloimmune platelet refractoriness becoming evident in your stem cell transplant patient, now that they look clinically refractory with poor increments, would you rather focus on DNEG, major ABO mismatch, minor ABO mismatch, preserving the CMV neg-neg double axis, or provide HLA matched single donor apheresis platelets over random buffies? Okay, so I think everyone's on the same page there. Okay, so to conclude, for ABO stem cell transplant mismatching, the clinical significance of this is still controversial, but immunoheme syndromes are well recognized, and we want to give blood product matches to minimize harms to both the graft and the recipient. So we prioritize being peacemakers here. Desensitization should be less of a focus or an issue in our care. I would say it's the most subordinate of everything on this list. And for special needs, we care about irradiation. The question that institutions have to decide on is how long to keep providing that for. And we can probably forgive CMV neg, seroneg donors in dual inventory management. Finally, HLA sensitization imperils both the graft and platelet transfusion responsiveness, as well as freedom from FNHTR. So whatever we can do for discretionary blood transfusion avoidance, especially for ERA plastics before BMT, let's do it. All right, thank you everyone for your attention and allowing me to go over time. So that concludes the presentation, and we'll move to the Q&A period now.
And that concludes the presentation segment of the webinar. We will now begin our Q&A session by addressing questions submitted via the chat box. We will give participants a minute or two to submit their questions. After we have answered these, we will take questions by phone.
While we're waiting, I want to apologize for going over time. Okay, so a question from Julia Hendry. With your T labeling convention, what do you do in the case of multiple stem cell transplants of different groups? There, we boil down to group O red cells and AB plasma-containing products as the first priority. So as I mentioned, AB is really hard to procure for platelets and plasma. And so there, as we cross the ABO barrier, for group O containing platelets, we will actually PVR plasma volume reduce high titer platelet donations. What may be coming in Canada, and I can't verify this, but it's possible that in the future our group O platelets will have some tighter information on the bag so that you can know to avoid certain group O platelets. There are so many grafts to respect, and in these cord bloods, we often see 3 or 4 different blood types at the table. Eventually one will engraft, and at that point the choice becomes easier. But in the interim, the more complexity or disagreement you have between rival parties, the more you've got to boil down onto simply group O for the red cells and AB for plasma-containing products. And if you're worried about isohemagglutinins, stripping that high titer or high plasma-containing product down a little bit. So I think another question, do you change to the recipient blood type? I haven't audited to what extent we actually go through with that. We tend to just keep people in their TAO or T whatever status we list them as. But on occasion, if we had someone who's really engrafted and they come back 20 years later and it's an orthopedic surgery, we've on occasion said it's okay to totally flip them over because they've got a completely non-discrepant blood type, and it looks like there's no question about this. There's no DAT positivity any longer, and we can't see the offending isohemagglutinin. I don't disagree, though, with the practice of holding someone in a hybrid status, because if they ever come back many years later for transfusion, and by the way, this is the same argument for going on with indefinite irradiation, if someone is coming back to need transfusion many years later, that might already be a clue that they're relapsing. And if they are relapsing, the dual blood type may be recurring as well. So any intimation for a recurrent blood transfusion requirement suggests that you might have to respect their peri-BMT dynamism all over again.